A very warm welcome to all faculties, dignitaries, and the participants to the East Zone Indian Menopause Conference at Gorakhpur. I owe a warm welcome to you at Gorakhpur, as you have been a big participant to make our all previous conferences a large success. I regret that I am not there personally to welcome you due to very genuine reasons, yet with my heart and with my all emotion, I owe a warm welcome to you. Hope you are having a very good stay and a very good academic feast. So we bring greetings from Lord of Buddha and the Guru Gorakhnath, who is the eternal ascetic, who says we can never obtain peace in the outer world until we make peace with ourselves. And menopause is also that very pertinent period of human life when we have to be with peace with ourselves. Now, in last 3 decades, there has been a rapid change in the human civilization. We are connected to every part of the world and they are influencing our thought process. And as a doctor, we are also having the many issues which are related, which are pertinent to every part of the world. But at the same time, it has put us a very difficult challenges also, because we have to think locally, we have to act locally. What are the difference in culture, way of living, phenotype, and physiological in different places of the world. And a glaring example of this haziness, this confusion in medicine is approach to menopause. And in next 15 minutes, I will put certain thing very clear that how we can make a holistic approach to menopause and the comprehensive and the compassionate use of medicine to make menopause a very comfortable and the graceful period of human life. So menopause is also wholesome. Every age is wholesome as nature has designed. And how our women and people look at it, that is very important. And our expectation, what we expect from ourselves, what we expect from healthcare system, that we make this period of life very happy and healthy. It is a natural gift to women or some punishment. We have to think, we have to improvise. Yes, it is a natural process of life. And it is science or our aggressive reaction to issue of aging. So these are few questions. And as a Indian Menopause Society, we have been looking into the intricacies of menopause. Yet we have to always remember that nature is always and always giving, and the elder age is not exception to that. So menopause is an opportunity. We see as an opportunity because woman is like, she has finished all long year of reproductive turbulence, reproductive responsibility, family responsibility, and the duties. Clinician can take this point at a very positive opportunity, because if we give the good positive medical intervention, it offers years of positive preventive health care. And what we want to have, the prolong the life with maximum physical energy and optimum mental activity. That is our way to treat, way to deal with menopause. And we have to consider that it encompasses approximately 1/3 of women's life. And when we are having an increased life expectancy, we are more and more bound to see the elder people in our clinics for various reasons. So this is very important, that how we look at the menopause. And the India, what is a wonderful book by Atul Gaude, that is Being Mortal, tells a lot about the Indian and the Western way of looking at the elder age. And we can proudly say that in India, we have a very positive approach to elders, and they are part of family, they are part of life, they are part of business. And this is our way that we should retain these values, these family values, these respect to elders value in our Indian system. That is the one of the basic element of the holistic approach to what we say as a menopause. So with the all 2 days of academics, you must be knowing that it is a transition phase from reproductive to non-reproductive. It is a protective phenomena, because women at elder age cannot undergo the pregnancy and all the hazard, all the turbulence of the labor. And we must again say that women must accomplish their reproductive responsibilities at a right age. It is a signal set by nature for beginning of maturing. You are mature, you are aged, and you have some other responsibilities to society and to the life. That is the other part, that is a signal, and it may accelerate the process of non-communicable disease as a total part of aging, but it is not necessarily universally. So this is very important, that if we have a good lifestyle and a good thought process right from the young age, then the menopause or the elder age is as good as any age. So menopause defining, it is again a very complex issue. So right from the climacteric, perimenopause, premenopause, and the induced menopause, we have a lot of words associated with menopause, but it only tells that it is a long period of 5 to 10 years when you have the climacteric, like as irregular cycles and the declining estrogen level, to the complete post menopause when we have the cessation of menstruation, which is the specific event in the menopause. So this is very important, that it is like when the woman is coming at the 40, at the 45, that is the time that we can intervene with the healthy lifestyle, with the healthy counseling and the regular warning sign as per their clinical profile. So today, like the people have the pressure to diagnose menopause, like 20 years ago, it was almost automatic, but nowadays many women want that, yes, what is the reason that we don't have the menstruation, and sometimes we have to do for the AMH and the antral follicle and the transvaginal sonography. So average age of onset is around 46, and the duration for 95% of women, like from climacteric to the menopause, that is the 2 to 8 years, and maybe the 5 years average duration. What is the dilemma in defining and variation? What is early menopause? For some, even at the age of 50, it makes a question mark. For some, it is like 38, they say that this is the time for menopause. So early menopause is, which is a ethnic related. What is in our ethnic race? What is in our family? With this, we decide that what is it. And it can be considered around 38 in Indian scenario, and delayed menopause when it is more than 44 years. I want to say that the delayed menopause has got many health implications, and as gynecologists, we must be very careful. If it is delayed menopause, then there is a sign of any hyperestrogenism, like endometrial thickness, especially if they have the higher weight or the diabetes and the small families, and the postmenopausal bleeding, which is always an alarming symptom which requires a proper evaluation. So premature ovarian insufficiency is replacing term premature menopause, and in Indian setup, one clear message I want to give, that it is around 38 years if the woman is attaining menopause and the perimenopausal symptom, then we should term it as a premature ovarian insufficiency or premature menopause. And what are the criteria? High FSH level and oligoamenorrhea for at least 4 months. So it is not a one-point diagnosis. It is an opportunity. What we say when the woman having the irregular cycle, delayed cycles, or something related to health, like a fatigue or something. Now, this is the time that we can intervene many positive lifestyle intervention with diet, with exercise, with drugs and everything. And why this is important, that these are the two transitional age, that is adolescent age and the menopause age. So in adolescent, the girl, they have not experienced life. They may listen or they may not listen. But at this age, around 40, 45, 50, people have lived life. They know about the value of health. And if we say something very specific about diet, about exercise, about any drug intake, about their change in life pattern, that makes a very positive impact, because they listen to us, and the compliance and the acceptance is much higher. So this is a real opportunity. So we should always, menopause is area and where we have to take our Indian perspective. And as our life expectancy is increasing, and we are 1.3 billion people, we are expected to have more than 100 million that the aged more than 50 years, and about 50 to 60% out of them are the women. So we as a gynecologist have a lot of responsibility about it. Secondly, the Indian women attain around 7 to 8 years earlier menopause. So for us, early menopause is 38 years. And that's why the woman can have the menopausal related issues. We will not say it is disease, but issues in the Indian women, and we are more prone, the more focus, the first priority is the bone health. That is very important, and the cardiovascular health, because osteoporotic fracture can occur 10 to 20 years earlier in India, and the first MI can occur in 4.4% of patients. So our race is different, and we have a large volume of elderly women. So we have the lot of responsibility to having the holistic approach to menopause. A third important public health problem is the breast cancer is second most common cancer in Indian women, and incidences peak before age of 50 years. And again, the Indian women tend to have the breast cancer at an early age. So our screening criteria, our approach criteria should be different from rest of the world. And it again says, now this slide is very important, because when we talk about menopause in the conferences or something, we tend to forget that the 72% of these menopausal women are in rural area, and they have their own issue. They have not that access to healthcare. They don't have the access to many drugs and the some screening procedure. And in the coming years, like these are the rural women, rural families must be our priority when we talk of the holistic approach to menopause. So this slide says that the estrogen receptors are everywhere. So every hormone receptor is everywhere, and it is the receptor acceptance where it is the hormone is there and receptor is there or not. So that's why the cessation of menstruation or the menopause can cause the differences in all symptoms. It is not only the cessation of menstruation. It can help, it can affect brain, it can affect breast, eye, genitourinary tract, ovaries, skeleton, skin and hair, liver, and the heart and blood vessels. So it is all about hormone, it is all about receptor, and we have come to know now with the new technology that we must have both the hormone as well as the receptor. And the estrogen is a different, it can be friend, it can be evil. So estrogen is nothing that we want to push estrogen in any woman's body. It has a complex beneficial effect, and it has a complex deleterious effect on the body. So as a gynecologist, we must be very, very cautious about the use of estrogen in our prescription and the role of estrogen in our body. So this is very important, and these are all symptoms what we see when the woman comes to us for many, many issues, hot flashes, especially the mood changes, and the genitourinary symptom, cardiovascular disease, and the osteoporosis, and in the later age, again, the loss of memory and the cognitive disease. So this is important. The age of menopause has been almost constant. It is almost around 40 to 45 years, but the life expectancy has increased, and we must be ready with our knowledge and a altered approach so that we can give a healthy and happy life to all our elder women. So individualized plan is very, very important, and we must differentiate. I will say very, very aggressively and emphatically, menopause itself is not a disease, and we must distinguish between symptomatic and asymptomatic menopausal women. So every menopausal woman does not need any drug or something extra, but we have to have the differentiation between symptomatic women and the asymptomatic women, and for what complaint she is coming to us. So this is very important, but the preventive and the promotive health strategy should be there for everybody. So it is about all quality of life, and quality of life, quality is the thing which matters different, which have the different perspective for everybody. So one can be very happy with the like this, that weight and that color, and one cannot be happy. So it is like a personal perspective, and as a medical care person, we should not emphasize our outlook to them, but we have to understand them. So this is very, very important, and there a lot of studies are MHT and what is the related quality of life. So this was important study because it is a warning. This is the Women Health Initiative and Nurses Study. Actually, 95, around 10 years, the aggressive pushing of the menopausal hormone therapy for the menopausal women. And then we got the backlash of the WHI study, which showed a sudden increase of breast cancer, cardiovascular disease, and thromboembolic phenomena with use of menopausal hormone therapy. Study was interrupted because of the high risk. It was not ethical to continue, and we had to look back. And that's why we are here to see a very cautious and a very cool, compassionate, and the holistic approach to menopause, and we need to revisit. So we came to know that when we give estrogen or the menopausal hormone therapy, ovary, breast, and endometrial, as the estrogen receptor are there and the progesterone receptor are also there, and when we give them after certain age, they may have the increased risk in those women. So these are all the new study which says that the non-cardiovascular disease outcome was during the 6.8 year, and we have come to know that it has got what the increased risk of venous thromboembolism, biliary tract surgery, and the trends in other disease were also not favorable. So these are few new studies which we have actually compelled us to review that the hormone, it is menopause is not the absence of hormone and we push the hormone. It is a part of aging, and many times we have to go through the nature and we have to develop and grow with the nature. So these are all new researches, the latest paper which says that where the menopausal hormone therapy can be a little help, and when we should consider and when we should not consider. So one thing is the symptomatic versus asymptomatic, and the second thing is the some reproductive issues. Contraception is a dire need for the perimenopausal age group because they don't want at all pregnancy, and if they get pregnancy, then the termination and everything can be very, very complicated. So it is a very important area that we help them in choosing a right type of contraception which is safe for them. So long-term IUCD is good, LNG IUD if they have the associated menorrhagia or the small fibroid, and now we have got the progesterone only oral contraceptive with drospirenone, which can actually change a paradigm shift in the contraception for all age women, which will be having no estrogen but with having the progesterone, which is having the anti-mineralocorticoid activity. So that is the progesterone only drospirenone. So we have to grow with our times and what is needed with the contraceptive option, and the unmet need has to be fulfilled for these women. A second spectrum of this is that today women are marrying at 35 age and they have a very short reproductive lifespan, and when they want pregnancy around 40 years, then we should have a aggressive management, and if they don't conceive within 1 to 2 or 3 to 6 months, the ART technology has to be used at the right time and at the early time. Otherwise, we have to have the only option for the oocyte donation, and we have to be very careful and counsel every woman that we have the more chances of pregnancy loss and chromosomal abnormalities as well as the pregnancy complication. So the marriage and the childbearing at right age is also very important. Now, I will be quick with symptomatic. The patient comes with few symptoms which is very, very common, and one is the hot flashes, and they can have mild, moderate, or severe. And when it is severe or moderate or it is disturbing their lifestyle, then we have to treat them. So we have to understand symptomatic versus asymptomatic and the grading of the vasometer signs, and that is the hot flashes. How we manage the lifestyle modification, good diet, rest, good sleep. So one thing is important. And second is the estrogen therapy is the most effective therapy for the hot flashes. And others are the SSRI, gabapentin, and clonidine. So beside the estrogen, we have to consider these drugs also, and we must have the knowledge for these drugs. So phytoestrogens, a lot of advertisement and a lot of things because they are non-hormonal, but they have not not been found to be effective for improving hot flushes, and the estrogen is the most effective drug. Vaginal atrophic symptoms are again the second common cause with which the elderly women come to us, and we have to look for it, that what are the physical signs, that is reduced vexillary vaginitis, atrophic vaginitis, and we can treat them with the with the moisturizer and the local, that is very recommendation. So this is very important actually, because local estrogen therapy does not have the systematic side effect, and we can use it at the right time and for the right duration. And the prevalence of urogenital symptom in postmenopausal in Indian study is quite good. It is around 10 to 15%. Secondly, women come with that recurrent urinary tract infection. That is one of the very, very important complaints, and these recurrent UTI, if they are not treated properly, they can lead to kidney damage and the pyelonephritis. So the proper treatment of recurrent UTI in elder age is very, very important. It can be done as per culture sensitivity or in chronic low dose prophylaxis or post-coital or self-administered prophylaxis, which is the latest recommend that the patient can take antibiotic prescribed nitrofurantoin, ofloxacin or desiflexin post-coitally or the self-administered whenever she thinks that these are the symptoms, and they are very, very effective approach to treat the recurrent urinary tract infection. Sexual health overall is it is not to be taken only as a part of the menopause related genitourinary atrophy, but it is taken as a multifactorial issue, and the emotional relationship and the overall health and the family circumstances has to be taken. However, the good option are the vaginal lubricator, local estrogen therapy, and sometimes the Tibolone. Now, mental health issue for the elder people, it is a very, very important area where we need to work on it, and we see there are 3.7 million Indian with dementia, and out of which the elder population constitute a lot. They can have memory loss, difficulty in communication and language, and it is not treated by the menopausal hormone therapy. But what we can do for them, that is a overall good health, exercise, maintenance of active mind, playing, reading, writing, social communication, no alcohol and smoking, and measure to reduce metabolic disorder. So it is an importance of social network, and we as an Indian are the privilege to have a very warm social and the family life. And again, I say that it is very important that we maintain these values in our family and our society. So sleep, cognitive function, depression, the mood changes are very common because the people are facing death, the children are separated. There are so many things which can make them sad, but this is again the philosophical approach to the life and acceptance of life, that is very important. Yes, sometimes we can prescribe antidepressant and anxiolytic and the sleep tranquilizer, but actually we have to be very, very careful that they can be very fastly addicting, and we have to improve in overall situation. Now, very, very important issue for our country, because after elderly age, the woman specifically after estrogen loss, there is a rapid turnover of the bone turnover, and there is a rapid development of the osteopenia and the osteoporosis. So it is important that we remember that in the reproductive age women and adolescent women must have a good calcium input, calcium, vitamin D3 and exercise. If we have a good bank balance at that time, then elderly age will also be having a better peak cell mass, peak bone mass, despite having the menopause. So these are all Indian studies which shows a high level of calcium and vitamin D deficiency, and we suddenly find women with the silent fracture, silent hip fracture, spine fracture, and firstly, we diagnose osteoporosis or osteopenia when a woman gets the fracture. And we have all experience in our life when the patient, woman or man have the hip fracture, there is a 25% increase in mortality, and sometimes they have a long-term loss of mobility. So we have to be careful that we listen to them. When we talk about the back pain, we see their height is getting reduced. Also, I want to emphasize that the bone health is related to depressive symptom, as well as the atherosclerosis and peripheral vascular disease and the cardiovascular mortality, because vitamin D receptor are present in the smooth muscle cell of arterial wall. And we have now recognized the polymorphism of vitamin D receptor, which may again contribute to common risk between osteoporosis and atherosclerosis. So this is very important understanding right lifestyle right from the beginning. Secondly, listen to them, see to them that they are having calcium and the vitamin D deficiency, and relate them that because it is not only a disease in isolation, it is affecting their cardiovascular health also. So a good amount of calcium is needed for these women, and this is an important public health intervention. Around 1200 to 1500 milligram per day calcium and vitamin D from 400 to 800 IU per day, along with the cessation of smoking, fall prevention, and exercise. We must tell them, we must inquire them what they are eating, and a good serving of milk, yolk product, and the fruit juice and the other calcium rich diet we have to say. So this is very, very important. For every research, whatever done by orthopedician, by the physician, but the calcium and vitamin D is the basic element which is considered along with the other drugs. So this is very, very important. The point of caution is that hormone therapy is not recommended for prevention or treatment of osteoporosis. So this is very, very important. And the next position statement is that the target calcium intake for most menopausal women is the 1200 milligram per day, and we have to maintain the vitamin D level of the 30 nanogram per ml. Now, it is not only the bone health, it is not only the cardiovascular health. I will like to emphasize that calcium has got many benefits on many systems. It has reduction risk of colorectal cancer, reduced hypertension, decrease obesity, and this is very important. And it does not increase the incidence of the renal calculi. It may rather decrease because of the decrease in oxalate absorption. So it has got a wide beneficial beyond bone health, and this is our duty that we really counsel the people. We really have the public awareness program that how much the calcium and exercise and vitamin D is needed for it. Bisphosphonate and the other parathyroid hormone are the other drugs which are used by the orthopedic person, but we must know that we have the other drug also, and the raloxifene we can use in the elderly age. Beside this, we must identify what are the high risk factors like a thin, small framed woman, use of bone-losing medicine, sedentary lifestyle, and the rheumatoid arthritis. So we have to pick up the high-risk women, and they might need the higher dose of calcium and vitamin D3. See whether they are on tranquilizer. What I say, if they're for sleep disorder, for mood disorder, we give them certain drug, and it can cause visual impairment, it can have the cognitive impairment, and they are more liable to fall, and they are more liable to get the fractures. And in our homes, we must have a friendly approach, not a very complicated design for our homes, so that they can roam about safely. PCOS is one thing which we are struggling. Gestational diabetes mellitus is one thing we are struggling, and all these women can have metabolic syndrome in menopausal age. So 33% of PCOS women can have metabolic syndrome, and when the PCOS women become elder, it is our duty that we warn them beforehand that you must have the yearly weight, blood pressure, sugar test, and the waist plan. And if the PCOS woman can have all long-term consequences like cardiovascular disease, diabetes, cancer, sleep apnea, and the psychological problem. So we can think of the insurance, special insurance for the elderly people, or medical insurance. They don't like elder people. They don't have a good premium for that. But it is time that we look for the all screening investigation and the positive preventive health visit, so that their health issues can be taken very well. So finally, a last few word about menopausal hormone therapy. I think that you have been covered in the last 2 days, but we must know what are the indications, that is hot flashes, urogenital atrophy, and bone loss in early menopause, not in late menopause. And contraindication are hormone dependent cancer, high risk of breast cancer, impaired liver function, thrombosis, venous thrombosis, and the established cardiovascular disease or undiagnosed vaginal bleeding. So we must be very, very clear. And what we have, the good drug, good knowledge of drug, minimum duration, and the good screening protocol. So it can be the estrogen, and I wish to say that the transdermal estrogen, now it is available and it can be the best choice because it does not have the systemic effect on the triglyceride, CRP, and the SHBG. And the progesterone is something which is different in every menopausal hormone therapy, and we have to understand every progesterone. Raloxifene and tibolone are used for some time for the menopausal hormone therapy, especially at the elderly age and for certain indication, and we must know where to use them in that. So this is very important. Early menopause, iatrogenic menopause, 3 to 4 years up to normal age of menopause, we can consider menopausal hormone therapy because it have the long lasting beneficial effect. So duration is of the therapy, you have to tailorize doses, you have to be titrated to the lowest effective dose, and you have to counsel. It is not like a multivitamin, it is not like a something drug over the counter. It has got a wide implication in our body, and the preventive, like what is her blood pressure, what is, you have to come for the counseling for it. So this is very, very important, that it is a part of overall holistic approach to menopause. Diet, exercise, family environment, social life, smoking cessation, alcohol cessation, consumption cessation, and some way the drugs have got their own role to play, and it must be individualized and tailored. This is very, very important. A lot of word about phytoestrogen have been told, the soy protein, because Chinese, Japanese, they are having a very healthy elder life. So we have to look for them, what makes them happy and healthy at elder life, and it is certain diet which is considered beneficial. And I am sure that in our country also we have many things which are beneficial, because we see many women who age gracefully and who live their life with the full enthusiasm and with the activity up to the later age. So it is all about the healthy lifestyle, healthy thought, good thought, positive thought. Nothing we should not fear age, we should not fear death. So this is the part of life, and that philosophical approach, that all discourse and that social life, that is very, very important, and a very respectful attitude towards the elder. So this is very important. Finally, we are born out of diet. Our all body is made of all diet. So low salt, low sugar, maintenance of a good body weight, and a good exercise is something. So positive thinking and social network, that is the very, very crucial thing we have to maintain about it. And economics of menopause management, I think as an Indian menopausal society, we have to think for the economics of menopause management. We still have a weakness in our public health system, in a good insurance system, and the menopause is a critical window, and we have to watch for our senior citizens. So elders are always valuable with their experience and wisdom. Asia have been pioneer in respecting the elders, and let our society and health system sensitive and caring for them. And caring is beyond medicine. It is our holistic approach to life, as old age is waiting for all of us on journey of life. With this, again, a warm welcome to everybody, and I seek everybody's support for my Foxy presidential candidature. Election will be held next year, because we have to target the people who have worked for the public health. And I can say that we all together can make a change for our country with this Azadi Ka Amrit Mahotsav. Thank you very much.